All right, welcome everybody. Our next lecture or notes for you guys to take is looking at injuries, specifically to the joints. So we'll summarize a little bit about joint classification, the anatomy of the joint, things that can happen, and how we treat them. Okay, so we'll start basically with classification or categorization of joints. All joints fit into one of these three categories: fibrous, cartilaginous, or synovial. And just up here, I also talked about how joints, also known as articulations, but joint is the more common term. Okay, so fibrous joints, they are immovable, they are set. Um, this is where bones have become fused together. Okay, so the best example of this is in the skull. You have different skull plates, the frontal, parietal. Those get fused together. Okay, so when you are in utero, which means in the uterus, before you are born, those bones start to fuse together and then they finish fusing together in the first 6 weeks of life. Might be a little longer for some babies. When you get the soft spot on the head, it's the final closing up of the two parietal plates. Next up is a cartilaginous joint. These are slightly movable, but they do not have a large range of motion. So again, we're staying with best examples. Best example is the vertebrae and the spine. They are pretty much stacked on top of each other, but there is some movement, right? So you can bend your back. It's not completely fused. The last joint is the ones that we are most, we use the most, we probably know the most about, most familiar with. That's the word I'm looking for. And that's synovial. Okay, these are freely movable. Knees, elbows, shoulders, fingers, those are all synovial joints. And that word synovial comes from the fluid that is in the inside the middle of the joint. Okay, or actually probably, that word means joint. And you have the synovial membrane and the synovial fluid inside of the synovial joint. Okay, I should look up that root word. Okay, so these are the types of joints that you have probably heard of before. These are all the types of synovial or movable joints. Okay, so we will look at each of them individually. So this is just the list here. We'll go through them one by one. Pivot, hinge, ball and socket, saddle, condyloid, which is also known as ellipsoidal, and a gliding joint. So we'll look at each one. We'll see a picture of it. I'll give you kind of how they work and how they move. All right, so I have ball and socket first, and the reason that it's called a ball and socket is the bone has a rounded end that looks like a ball, and there is a socket or cup-like structure of the adjoining bone where it sits inside of. Okay, so this would be the humerus and the shoulder, poorly drawn. The other ball and socket joint is the femur into the hip. Okay, so these are where our limbs hit our body. Now, with a ball and socket, because you have a ball sitting inside of a socket, it has a really wide range of motion. Okay, I mean, obviously, I can't take my arm backwards, past my head, but we have this huge range of motion. Okay, and you've just done muscle movements. The ball and socket joint is capable of that circumduction movement, abduction, adduction, and rotation. Okay, so the shoulder joint can do a lot, ball and socket. Hip joint, for most people, their hip joint doesn't have as much range of motion as the shoulder. Okay, that's typical unless you're like a gymnast or something who's worked really extensively on their hip and upper leg muscle flexibility. The big reason for that is if you think about the quadriceps and the hamstrings and the glutes, those are three massive muscles that are used a lot. So they often end up tight, especially in humans like us who spend a lot of time sitting down. Those muscles end up getting really tight and inflexible. Okay, so we will often find that the range of movement or motion in the leg is more limited than the arm and shoulder. Okay, the next joint is a pivot. Pivot joint allows rotation. Okay, so you have two bones next to each other, and one sits kind of cupping around it, allowing it to move this way with some support. It's hard to do this on either side, right? So this hand is supporting around it, allowing rotation. We have two good examples of this, which is the neck. Okay, you have that rotation with the atlas and axis bones rolling past each other at the top of the spine. And then we also have a rotation piece in our elbow. So if I scoot my chair back, like when you turn your hand over, a lot of people think that they're just rolling their wrist and it's the wrist that's turning, but it's not the wrist, it's actually the elbow. So if you hold your elbow and forearm still, you can't rotate your wrist. The rotation comes with the forearm, and that rotation is in the elbow. Okay, so that's pivot joint. Hinge joint is classic, like a door. We have a hinge that allows it to open and close. Okay, so you have, again, it's, there's some elements that are similar in all joints. So you have something that sits inside of something. Okay, it's not a ball and socket where it rolls, but you do have a piece that sits inside another to allow that hinging motion. Okay, and a hinge joint for most people won't go beyond 180 degrees. Now, some of you will find that you might know people who have larger range of motion around their elbow. Typically, that happens because, or around their knee or in their fingers, and they might call themselves double jointed. It's not actually a double joint. There are two things that happen. One is that they have really flexible muscles to allow that range of motion, and they have a slightly different shape bone here, which allow, like, you can see on the edge here, this would be the humerus, and then this would be radius and ulna. This lip here and here is going to limit the range of motion. So some people have a slightly different morphology in the bone shape, allowing it to open more. It doesn't mean that it can go both ways and it's double jointed. It just means in that joint it has more movement possible because of the morphology of the bone and the tightness and the flexibility of that muscle. Okay, next up is the saddle joint. Thumb is a saddle joint. This allows it to hinge and go side to side. Okay, like opposite, it's not the same as your fingers. It's hard for you to move your fingers as much side to side as you can with your thumb. And if you look at the diagram here, you can kind of see what it is. So this would be the metacarpal. I had to think about that for a second, of the thumb sitting onto the carpal bone of this side of the hand. Whoops, I didn't mean to go forward. And it sits into it, and it allows it to rotate and go side to side. And that's a saddle joint. And hopefully you can see why it's called a saddle joint, because it's kind of like, the bone is like the rider sitting on the saddle of a horse. Okay, next up is condyloid or ellipsoidal. And that ellipsoidal name comes from the shape of one side of the bone. Okay, so similar, shares some things with a ball and socket joint, but instead of it being a rounded ball, it's more ovular or oval. And then it sits into, in the hand, you have the carpal bones here. These are all carpals. And it has this kind of oval shape here that sits into the opposite oval shape of the radius. Okay, now because it's oval, it allows movement this way, and it can hinge. It's like a hinge-like motion back and forth, going this way and this way. Now, most people know the wrist is the best example, but your fingers also have a condyloid or ellipsoidal joint between the metacarpals and the phalanges. Okay, so that would be, you have 3 phalanges on each finger, so 1, 2, 3. So it would be the joint here, the top of your finger. Okay, so like you can see, your finger can go back and forward, right? So that's because, like your wrist, it can go both ways because it has that ellipsoidal joint. Now, if you try and bend your finger above that joint, so this joint here, sorry, this is hard to show on the camera. At this joint here, we can go back and forward, right? Now, if we go one knuckle up, you can't go back. It only goes forward because that is a hinge joint. Okay, and it has the morphology of the bone limits that movement. Okay, next one up is a gliding joint. Okay, I think this is our last one. Yes. Okay, so a gliding joint, this is where you have two surfaces that slide past each other. Okay, and the range of motion here is really, really limited. Okay, and it's limited, well, what limits the range of motion is not the morphology of the bone or the shape of the bone, it's all of the soft structures around it. Okay, so you think about your spine is a gliding joint, each of those in between each vertebrae, they're just stacked on top of each other. It's all the ligaments and muscles that surround the spine that hold them in place. Okay, so we see it here, movement is limited by the structures surrounding them. So that would be spinal erector muscle going up and down, and all the ligaments and tendons that feed into the spine. You also have a sliding joint between the tarsals and the foot. Okay, so we have lots of irregular, or they're not irregular bones, they're actually short bones, tarsals, okay, that have kind of fused, they're not fused, and they'll slide a little bit past each other in your foot. Okay, those are the joints. We have gliding, condyloid, saddle, hinge, pivot, ball and socket. Now let's look at what's actually going on inside of a joint. I use the knee as an example here because this is probably the one we might be most familiar with in terms of the names of the ligaments and structures. Okay, so the first thing that holds a joint together is going to be ligaments. Ligaments are these strong, fibrous tissues. They are white when you see them. And they attach from bone to bone. So in this diagram, you can see 3 of the 4 ligaments in the knee. Okay, so you have the medial ligament that goes from side to side. This is on the inside of your leg. Then you have the lateral on the outside. At the back, you have these 2 going here, and you see how they cross. Actually, it does have both of them shown here. It's just not very clear. Okay, so here we have the posterior cruciate, because it's going this one, and the anterior, which means to the front, the anterior cruciate coming across here. Okay, so those are the 4 major ligaments. Okay, and their names tell you something about it. Medial means to the middle of the body, lateral means to the outside of the body, anterior to the front, posterior to the back, collateral meaning going sideways, and cruciate meaning crossing. Okay, so that's the first thing. Major structure in a joint is going to be the ligaments. Okay, really, really important. Other structures we have is the capsule, the bursa, and the meniscus. Okay, so the joint capsule is basically a sac that seals the joint and surrounds the whole joint. So in this picture here, you can't see it, but there would be a sac surrounding the whole of the joint underneath the muscle tissue. And it basically keeps it sealed. This joint is filled with fluid. That joint capsule can also be called the synovial membrane. It's filled with synovial fluid. And basically, it provides a little bit of extra support because you have this, it's more thick than water or more viscous. And it provides a little bit of support. But also, if you think about having fluid in the middle of a joint, it provides lubrication to allow the joints to slide, the bones within the joints to slide past each other. The next structure is a bursa. And basically, you have these separate little sacs of some synovial fluid that are concentrated in areas of great friction. So like between the ligaments and the bones, in these areas of high pressure, get these little bursas or extra padding sacs filled with fluid to protect them. The last piece is the meniscus. This is a fairly common injury amongst athletes, is a torn meniscus. And we'll talk briefly about what that is. So basically at the end of each bone, if we go back here, you have these discs of cartilage. Okay, and they are super, super smooth. Okay, the meniscus. The idea of them being smooth is they slide. They have this really smooth articulation, so they pass. They allow the bones to continue to move without much rubbing. Now you can, if you damage your knee, you can get the meniscus to be torn, and basically that causes this catching motion. So as they move, as the knee joint moves, it gets caught on the meniscus, and then it will suddenly give, and the articulation or movement within the joint won't be smooth, and you'll feel this kind of catching. I had a torn meniscus in my knee a couple of years ago, and I could really feel it catching. Luckily for me, it wasn't really that bad, and I was able to rehab it without surgery. But you could feel it was uncomfortable because every time my knee moved, which was every step I took, I could feel it kind of catching a little bit, and it wasn't as smooth. You might remember in the first semester I brought in some pork bones, and I showed you the smooth edge of the ends of the bone, and that would have been the cartilage meniscus. Okay, let's look at how joints get damaged. Basically, a joint gets damaged when a force is placed upon it in a way that it can't control. And there are three types of forces, and they're shown here. First, we have compression, that would be pushing together. We have tension, that's pulling apart. And then we have a shear force where we have a tearing. Okay, so you can see in each of the, we see the ball being squeezed, the rope being pulled apart. And with shear, you have like opposing forces going adjacent to the fibers. Okay, so tension is going directly this way and this way. Your muscles are already under tension. So you have, with shear, one will be going this way and one will be going that way in a tearing motion. Okay. All right. So if we look a little bit about those three forces. The first one, compression. This is not that common an injury because your joints, your tissues are capable of dealing with a fair amount of compression. Now, most commonly what happens, compression injuries in sports often result in contusions or bruising. If you think about something hitting you, it can leave a bruise. For that impact to hit you in a joint and actually break the joint apart, the force has to be really, really high. So the only really bad compression injuries you're going to get in athletics are going to be, or it's not really going to be in athletics, it's going to be something like motorsport where you can get crushing injuries because the forces applied are so much greater. Now, compression can lead to shear forces. So like you might have seen an injury, perhaps in football, you see this a lot where you get a chop block and somebody comes through and hits the side of the knee. Although it's compression, you have one part of the knee staying still and one part being moved over, and that actually produces a shear force. It's the shear force that damages the knee. Okay, so second force is tension. Your tissues are actually at their strongest when they're under tension. Okay, so to actually pull a muscle apart or tear a ligament, if you're pulling along the ligament, is really, really difficult. It's like if you take a piece of paper, let me see if I got one here. The amount of force I have to generate to actually pull the paper, I'm pulling this as hard as I can and it's not budging, right? So if I try and pull the paper apart, because the fibers of the paper run this way, I can't do it. Same thing with like if I compress it, I'm not going to be able to damage it. Now with tension, occasionally we can get tension injuries. Usually that comes when there has been some damage to the tissue already, or that tissue has been gone through like years of getting tighter and shorter. But it still takes extreme force to get failure that way. The one example would be an Achilles tendon snap. Some people say that when this happens, you can actually hear the snap like a gunshot wound. Okay, so the Achilles tendon snapping at the back of the foot, that would be a tension injury, but not very common. Now, the last one is a shear. Okay, so when you get forces going um, at 90 degrees to this tension, so tension is going this way, right? If we get forces going this way and this way, the paper will break easily, right? Because that's just tear, right? So a shear force is going to damage it much easier and more quickly with less force because it's not in the direction of the greatest strength of the tissue. So shear injuries are most common in athletics when we damage our joints. Sorry, let's wait for that to get out of the way. Most people, when they damage their knees, or I focus on the knee because it's an easy one to think about, but shoulders, wrists, it's usually where there's some shearing effect. Okay, and that can either result in a complete tear of, like we just saw, or it can involve micro tears where it just partly tears and then becomes damaged. Okay, so that's why when people damage their knees, it normally involves a change of direction. So if you're running in a straight line, you're following the line of greatest strength of your joint, you rarely see injuries. But it's when somebody makes a sharp cut where the force is being changed from straight to sideways where we see that injury. Now, one thing I will mention, I'll see if I can demo this. I did not practice it. If you have small micro tears in because of an accumulation of lots of little shear injuries in your ligaments. So I don't know if you can see that. I'll hold it up here. I've got loads. I just did 3 little tears in the paper. Now, when I apply tension force, you can get failure afterwards with tension if there's already damage to the ligament. Okay, so if you think about Kobe Bryant, when he in one of it would have been his penultimate season when he tore his Achilles and then shot free throws afterwards, there wasn't like this big force where it suddenly snapped. It would have been an accumulation of lots of little micro tears that finally caused it to fail under tension. Okay, let's move on. Let me go. Okay, so we're going to look at 3 injuries. I think I've got 3. Ligament sprains. So basically what a ligament sprain is, or a capsule sprain, is the overstretching of those support structures around a joint. Okay, so typically ligament, but can also be capsule, and it's usually caused by traumatic twisting of the joint. Again, it's that shear force, right? 2 opposite directions. You see here, one force that way, one force that way, there and there. It's that shear force that causes it. Diagnostically, what we see in the athlete is a deformity. So you might see immediate swelling. You might see some, it depends on the level of the severity of it, but you can see deformity in the position of the bone, and sometimes with like the ligaments and tendons being moved to one side. There will absolutely be pain. There might be something called crepitation or crepitus. And basically what that is, it's a grating sound during articulation. So as the joint moves after injury, you hear this cracking and popping. Okay, so that's crepitation, and there will absolutely be point tenderness. So the difference between tenderness and pain is always there. Tenderness is pain when touched. Okay, so those are going to be diagnostically what we're going to see. And with a ligament sprain, you can have a variety in severity. So we categorize them same way as a muscle strain into 3 degrees. So first degree, second degree, third degree. First degree being the least severe, second degree being more severe, and third degree being pretty bad. If we look at the symptoms, so ligament damage, first degree, there's going to be mild tearing. This is where you roll your ankle, but you can maybe continue to play. Moderate tearing is where you roll your ankle and you know you're done, and you might be done for a couple of weeks. and a third degree is if it completely tears, and then you're going to be done for potentially 6 months with surgery recovery. Always point tenderness, and again with loss of function, it's mild if it's temporary because you're able to keep playing. Moderate to severe, meaning you probably have to stop, and it's severe and that joint becomes completely unstable. Okay, it's impossible to bear weight. Range of motion, we're going to see increasing severity, right? So range of motion isn't affected on a first degree. Second degree, we see some decreased. And then with third degree, it's either going to be really decreased because the joint completely seizes up, or it's going to be increased because the ligaments have snapped and now it can just move without anything holding it back. Edema means swelling. So again, we're going to see a gradual increase in swelling as we move from first to third degree. And the last one is stress test results. Okay, so there's going to be no laxity in stress tests. So basically that means when you apply a stress test, you have them resist against and push against it. And with the first degree, there's going to be none. And there's going to be a lot of laxity with a third degree. Okay. How do we treat this? So treatment is fairly straightforward. We use, you may have heard of the Rice procedure. Now it's called Price because they want to add to protect on the top. So protect, you avoid further injury. You carry this person off the field or you have them hop on the other leg if it's one leg. Rest, you want them to stop moving so that they're not damaging it further. We want to ice, and ice protocol is immediately 20 minutes and then take an hour off and then 20 minutes on, hour off, 20 minutes on, hour off. And that can be done up to kind of 3 days, depending on the severity. But certainly through the first 24 hours, you should be icing as much as possible, but with that hour break between ices. Compress, so you can use an elastic wrap to wrap around. This isn't a support, like this is not a tape job. So you're not taping them up to go back out. You're putting an elastic wrap around it to compress the injury to try and decrease the amount of swelling. And then elevate, so lift the injury above the level of the heart to again decrease swelling by slowing blood supply into that area. The reason for the ice is twofold. I skipped past this. One, ice can have an impact of pain reduction because it numbs the area, but it also can slow the swelling response as well. Now, interestingly enough, that swelling response, there's a little bit of contention around it. Some physical therapists feel like you should just let the joint swell, as the swelling is a natural way to decrease range of motion and protect the injury. Whereas some others believe that when you allow it to swell, it slows down the healing because we can use other ways to protect the joint without having that internal swelling. Okay, so there is some contention and there is a difference in how some people treat that in terms of reducing swelling. Okay, follow-up treatment. This is kind of the protocol you want to follow. The first thing is you want to do isometric strength exercises to hold on to the strength you have in the muscle surrounding that joint. So what isometric means is contraction of the muscle without movement of the joint. So when you just flex your bicep without movement, that's isometric. My muscle is tight. I'm contracting it, but there's no movement. Okay, so that's an isometric exercise. Then you want to work on flexibility to maintain pain-free range of motion. If it hurts, then you go up to that point and not beyond. The second step, once you kind of got past that, is to go through isotonic strengthening. Okay, so isotonic would be the contraction causing that. So that's an isotonic movement. We have a contraction causing movement. That's isotonic. And again, you want to slowly build your way back up to where you were baseline before the injury. And then you can start applying braces to support. A couple of different types of braces. You have neoprene braces, which primarily are there to keep the injured area warm during activity, because a warm joint generally functions better than a cold joint. And then you can have ones with plastic and metal supports, which are there to provide more of a functional structural support to the joint. Okay, and then step 3 is to go back to participation without braces. Again, this is kind of a contentious point. For me as a coach, I don't want athletes in braces permanently, because when you constantly wear an ankle brace or a knee brace, your musculature is then relying on something external, and it can lead to kind of atrophy and dysfunction within the joint. So I was always coached up to have build back the strength so that you can participate without a brace, and a brace should only be a temporary thing. Now, there is, again, some controversy over this. You will see some coaches will require their athletes to always wear braces, whether they are injured or not, as a protection method. And then you will have some coaches who will require athletes to always wear a brace after an injury. That's kind of an interesting point to me as well. It's kind of a difference of philosophy. Okay. Now, one thing I should say is if you have a 3rd degree sprain, these exercises are going to have to follow surgery, right? So if we get a complete tear of the ligament, isometric building to isotonic is not going to work until that ligament has been surgically repaired. Okay, so that's the follow-up treatment we want. All right, next up we have dislocations and subluxations. A dislocation is an injury where the bone is forced out of its normal position. Okay, it's as simple as that. Beyond its anatomical limits and leaving the bone positioned outside. A subluxation is where you get a partial dislocation where the joint slips out and then slips back in. Symptoms for this are going to be deformity. If you have a full dislocation, it's going to look weird. You're going to have lumps where there shouldn't be lumps. There is going to be pain. There is going to be point tenderness. There's going to be a loss of strength and a complete loss of motion. If you dislocate your shoulder, your arm from your shoulder, you will not be able to move this arm. Okay, it will be kind of stuck. And you won't be able to apply strength. You won't have any motion. Okay, and it will be very painful. So here are some pictures. Obviously, you can see the deformity here. That shoulder has been dislocated. With the knee, it doesn't stand out as much, but if you look carefully, you have more of a swelling on this side as the femur has been kind of pushed to the side, and then fingers will stand out as well. If you want to see some, I think I showed them to you with the one with Joel Embiid who dislocated a finger and it was pointing out sideways. And I think there's one of Klay Thompson as well, both basketball players. Okay, so immediate treatments for dislocation, subluxation. You want to, first thing is check CMS distal to the injury. If you get a dislocation of a joint, sometimes it can trap nerves and affect sensation. That needs to be checked immediately. If there's any compromise, that's has to be kind of relayed to EMS really quickly. For most dislocations, or for any dislocation, it's going to be an EMS call. If the joint does pop back in a subluxation, they still need to see a doctor, but perhaps it doesn't have to be lights and sirens to the ER. Perhaps it could be next day, go to the specialist. After you have checked that, we want to splint the injury and make the patient comfortable. When that arm is dislocated or that elbow, gravity is pulling on the injury, and it makes it more pain, gives more pain to the patient. So you want to splint it so it's supported and held so that they're comfortable. After you apply the splint, you recheck CMS, and then you can apply ice, but do so in a manner that doesn't cause pain. Okay, if you drop a big lump of ice on a dislocated shoulder, you have to be very gentle, and perhaps you would use a slightly smaller bag. Really, really important, do not ever try and relocate the injury yourself. Okay, you want to let a trained physician do that in a hospital setting. You don't want to be doing that on the side of the field. No, trying to push the nose back into joints or pop things back in. Okay, you might have seen that in a movie or two, but it's not a good idea. Okay, so I'm slowly losing my voice here. Last one, and it is synovitis and bursitis. The names there from the root words you should be able to get. So we're looking at The synov, we know we're talking about either the synovial capsule or membrane. Itis means inflammation. Bursitis is going to be inflammation of the bursa. Okay, so that's what it is, inflammation and swelling of those particular structures. These are typically overuse injuries, okay, where you've been constantly throwing, moving in a certain way that's gradually inflaming that structure. You're doing it a lot, okay, it's repetitive. So, tennis serve, baseball throw, those are good examples. It's going to be painful. And you might get some crepitation if you are kind of applying resistance for that joint to push against. An example of this is bunions in your feet. When you see the side of the toe, you get a lump on the side. Now, females will sometimes get this when they wear high heels too much. I say females, maybe some males like to wear high heels too. But when you wear that type of high heel shoe, it puts a lot of pressure on the toes as gravity is kind of pushing down, and it can aggravate the bursa on the side of the big toe and lead to like a lump coming out of the side or a bunion. Okay, so be careful with the high heels. Treatment depends on the presence of swelling, right? So if we have swelling, we want to use Price protocol and ice compression elevation to try and bring the swelling down. If there is no swelling present, you want to do the opposite and apply some heat and limit the activity. Okay, so the heat can allow the joint to feel more comfortable and move more freely. And then you want to limit the activity to what is comfortable. With these type of injuries, it's really important to maintain range of motion and strength. So stretching, flexibility around the injury is really good. If this one persists, then you probably need to go and see a specialist. Okay, that's it for today. I will post the quiz questions up soon. And that's it. I hope you guys are doing well. I miss you. I hope you guys are surviving and finding ways to thrive in this weirdness that we are in. All right. Bye.